Thank you, Smarty, for having me to present this interesting and new development in terms of the tools, right, can be used for early intervention. And also, I would like to thank all the participants for taking your time off and attending this webinar with me. Okay, so let's, without further ado, we go over application screen. Let me see whether I can get the... Okay. Angela, just to check, um, you can see the screen clearly?
Yes.
Okay, perfect. All right, so let's move on. Right, so we're going to start with this lecture, the linguodontic paradigm, early intervention for growing patients, optimizing craniofacial development with Smarty AG kits. Right, so a very quick introduction. I'm a general dentist, a very curious one, and graduated since 1999, and I've been working on different areas in getting my fellowships, studying about implants, learning about CAD/CAM dentistry, TMD, laser, myofunctional, aligner therapy, doing my sleep training, teaching laser, doing some research, right, working on um, myofunctional devices, sitting on a board for the oral health therapist, and also being an editor for the Journal of the Oral Facial Myology and Myofunctional Therapy, and with the faculty for line. And now I'm helping Smarty in the R&D team to working on the sleep-related products. And today we're going to bring to you AG Kits. So it started in 2017, where I shared on the TED platform regarding the tongue being a very important part of our body in terms of helping us to achieve wellness, right? Having a tongue up, breathe through your nose is so important. Set up the linguodontic clinic, but later on we have renamed it to DP Dental Orchard, and it's still standing. I'm in here now, right? And it's been a journey, but I'll share with you how interesting and wonderful this journey has been. And in front of you is a 8-year-old boy coming to you with a deep bite, median diastema, some space loss for the eruption of the lateral incisor, definitely some crowding, curve of spee, right? And increased overjet with lip trap, right? And of course, on the facial part, you can see there's venous pooling, there's forward head posture. What would you do for this 8-year-old, right? Same thing for this 7-year-old. He has crowding uh, at the lower, but you can see there's not much primate spaces. And would you do a cleaning and send the boy off? What will be your thinking process sometimes when you're dealing with young patient like him? So we'll look further later on, and we'll see what are the hidden, right, danger of not being able to help them further. So to be or not to be, Hamlet, or for a dentist to treat or not to treat. Pediatric sleep-related breathing disorder. So for this situation, we do have anatomical airway collapse and altered respiratory control mechanism in both not children but also adults, as we know. It can be from a simple mouth breathing habit, which of course has uh, vast implication. Having primary snoring, which is still not being taken too seriously by a lot of people, right? And of course, the hidden upper airway resistance syndrome, which is, I would say, prevalent, but the testing that we can do is not able to pick it up so easily as we probably need to use PSG or polysomnography to actually help to identify, because the RIRAs and the arousal has to be picked up by more instrumentation. Then, of course, the well-known obstructive sleep apnea, uh, very end stage. But but is it all about just OSA? But these things that we are going to explore. Now we put it all together as a collective term, sleep-related breathing disorder, and sometimes it's sleep disorder breathing. So when we go through sleep-related breathing disorder, there's a cycle of obstruction, desaturation, and fragmentation. Partial, complete obstruction, resulting in gaseous exchange abnormalities. Then oxygen or desaturation happens, carbon dioxide level increase. Uh, it might trigger more inspiratory response and effort, but we're still not breathing well. And in the end, we might end up with arousal and many sleep fragmentation. And for a child, there's also a lot of symptoms that you can see from habitual snoring, paradoxical breathing, excessive sweating, um, bedwetting, and enuresis, neck hyperextension, right? Behavior-wise, they can be a little bit more active, right? Learning activities, right? Even morning headaches. So long while ago, working with some undergraduate students and also some pediatric doctors and sleep physician, we tried to come up with this handbook and using this acronym called HOUR. Observe for restless sleep, watch for unusual sleep posture, and also listen for habitual snoring. And try to educate the public as early as possible, pick up these issues and maybe escalate it for more uh, like physical or physician examination. So this optimal craniofacial growth with malocclusion, how prevalent it is? Um, Usually it's getting between this 1 to 6% number. And if there is obesity, the prevalence can go up to 13.3%. So this disease burden affects this amount of population. But to be clear, this is OSA, right? And if there's not enough rest, sleep, right, oxygen, a lot of the biggest issue is neurocognitive impairment and learning difficulties, yeah, behavioral issues. Then we have our craniofacial changes, growth, development, deficiency, stunted growth even for the whole body, and later on, the whole metabolic issues, yeah, cardiovascular issues do develop. One study in Japan who look at about 25,000 children, and from there they realized about almost 9.5, almost 10%, yeah, do exhibit this kind of issues in terms of loud snoring, daytime sleepiness. And then when they do further testing, of course, it again went down to the 1 to 6%. So I think the OSA numbers, right, 1 to 6%, but the sleep-related breathing disorder could be affecting the 10% range. Yeah, and this is also another epidemiology study showing that about 3 to 12% habitual snoring, right? So number is huge. It's just that sometimes we still don't have the correct or effective kind of testing. We have to depend on the PSG, but it's not that easily available, right, to the large population. So, what can we do? Maybe, yeah, changing habits. And what habits can we do first, right? Professor Kristen Gimino came by in 2017 at the Singapore Sleep Conference, and Professor To Song Ta, head of ENT sleep centers in Singapore, you know, helped to change this idea of mouth breathing is never normal, right? Or should I say, brought this idea of mouth breathing is never a good thing. Frequent infection, development of malocclusion, incorrect phonation, abnormality of body posture, and changes in sleep. And by his active work, uh, it got implemented into our national systems. And you can see now that it is sleep centers are also talking about it, right? So literally, it helps to reduce the collapse of upper airway, and many of the exercises involve the tongue. And why is it so? Because I think we can see by human design, we should be having our tongue up against the roof of the mouth almost 20,000 times a day for our breath, right? And also, when we are swallowing, almost 1,000 times, the tongue should be up against the roof of the mouth as well, right? This will be occurring many times in a day. And to do this well, I think it's good to have our tongue up in the roof of the mouth, waiting to do this two activity, including also talking and eating and swallowing, right? So if we keep our mouth open, the 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 air will leak out. There's no more suction. Tongue descends. But when the tongue descends, it can also flop back and really close down the airway. And that's why we talk about having this importance of tongue exercises, closing of the mouth, doing a myofunctional therapy, and only breathe through your nose to prevent the collapse of upper airway during sleep. So, from a habitual point of view, I think we're just glad that we have taken a lot no notice and putting the system into a national level initiative, right, in Singapore, right, to create that kind of change that we want to see. I think the next big move was this, right? In the Singapore Consensus statement is out on the management of OSA in 2025. And this is a very important component that I would like to share so that we know where we stand as dentists in helping patients, especially the young ones, right, to breathe better. This is published in 2025 by our Academy, right, of Medicine. And you can see that it really highlights a big issue where um, 1/3 of our population suffer from moderate to severe sleep apnea, right? This paper was published in 2012 then, and after 13 years since, the number has not dropped, and we are really calling for more collaboration. So what this paper is trying to do is trying to provide comprehensive guidance for diagnosis and management of adult and pediatric obstructive sleep apnea, and in consideration for application or for the recommendation of healthcare environment in Singapore, right? So we hope that we really set the stage, and this concepts and also guidelines can radiate out from here as well, and continue to concur with other colleagues around the world that has actually been establishing this act. So for adult, yes, we have oral appliances that can help with mandibular repositioning and relocate the jaw position to help breathing. But today we're going to focus on the pediatric side, right? And yes, the statement goes that we should do dental facial orthopedics, growth modification, orthodontics treatment is recommended for children with OSA, as also for myofunctional therapy, right? This summary is set to position dentistry within pediatric obstructive sleep apnea care, evidence underpinning the position. Good thing is that it is a framework appraised under the GRADE framework, and is done by a panel. It's a multidisciplinary panel from respiratory physician, otolaryngologist, pediatrician, dental specialist, and allied health professionals. So it's not just a dental point of view. It's actually a collective point of view and what needs to be done. So the central position is that this is a national grade appraised consensus situates dentistry within a multidisciplinary management of pediatric OSA. The dental role is to screen and to support, not to diagnose, but also not to abstain. We cannot sit by the sideline. The dental facial abnormalities is treated on its own merit. So this is important. We should already seeing all this deficiency, do something about it. Any airway benefit should be an associated outcome, right? We set forth, but we know that we might not always hit the mark, but we aim towards developing it. And sleep diagnosis still remains with the physician. Right. So the two dental statements that highlight an intervention is over here. The dental facial orthopedics growth modification, right, may be considered in children with primary O snoring, upper airway resistance syndrome, and OSA, which exhibit craniofacial or dental facial anomalies with hypoplastic or retinatic maxilla and mandible. So the grading is moderate certainty and conditional weak. I'll explain this part. So what's solid is correcting a hypoplastic retronatic jaw, justified on craniofacial ground on its own right. Cavity expansion alone is not a proven cure for ORSA, and airway benefit is associated, not assured. So for clinical application, we should screen for established craniofacial indicators, class 2 relationship, retronatia, maxillary constriction, for example, right, and treat accordingly, right? Refer to sleep physician for diagnosis and follow up with sleep monitoring. For the myofunctional therapy, it is considered as a treatment modality or adjunct treatment for mild to moderate OSA. Again, grade is low certainty, conditional, weak. So what is solid is a meta-analysis showed that AHI reduced by almost 40% with better oxygen saturation. Then the caveat is exercise protocol varies widely across trials. So adjunct, not primary. So offer as an adjunct to non-severe case through an appropriate trained external providers and frame expectation as supportive rather than curative. There's another statement that's also very helpful within the whole uh, um, consensus paper is this treatment risk factor assessment. It says that for children with OSA with clinical finding discordant with adenoids and tonsil hypertrophy, assessment of other factors, right, including obesity, right, atopy, dental facial anomalies, and hypotonia is actually so it's again graded low and strong, right? So it named dental facial anomalies among the risk factor. So what this show is that dentistry at these 3 points in the pediatric pathway, two are direct dental intervention, right? Both conditional recommendation, and one is a risk factor assessment, which is a strong graded one. So it is time for us to take action. So certainty, this is the point, right? When it's high, is that we're very confident the true effect is close to the estimate. So for low means the true effect may be quite different from the estimate. So we know that it can be done and achieved to a certain extent, but the reaching of that state has a variation to the outcome. Then strength of recommendation, strong meaning that do it for most patients, they choose it. And then for weak is that is recommended for the right patient. Choice depends on case selection and preferences. Then the next layer is good practice, sensible standard of care. What all this means, right? This supports recommend dental facial orthopedics and malfunctional therapy in selected children. Dental facial anomalies is among the risk factor that we should be checking on, right? The consensus is multidisciplinary. Myofunctional therapy demonstrates meta-analytical AHI reduction in mild and moderate cases, and correction of genuine maxillary and mandibular deficiency is independently justified as craniofacial crowns. What we don't want to claim is expansion alone is not a cure, right? It's not established as a cure. Assessment of dental facial risk is not diagnosing OSA, right? Dentistry contribute to the risk picture. The physician makes the diagnosis. Dentistry does not diagnose. Again, I think it's a repetition, but I think it's just a good important point to put through. It's done by the physician through the polysomnography and home sleep tests. No claim should be made that any appliance normalize AHI or treat apnea. Benefit confines to appropriate selected mild to moderate pre and peripubertal cases. So the dental facial deformities is treated, and because the correction is justified on its own, when a child is presented with a breathing concern, growth modification may benefit the airway as an associated outcome. Sleep diagnosis is screened for and referred, not exerted, and precisely a position of Singapore consensus paper. Okay. Then from the Asian Pediatric Pulmonologists Society, again, a medical group looking in. They're also uh, adding orthodontics and myofunctional as part of their algorithm for management. So it's published in the Pediatric Respirology and Critical Care Medicine. Sorry. Yeah, and they highlight the signs of obstructive sleep apnea syndrome. And if you take notice, right, like 7 out of 11 are actually oral signs: micronatia, high arch palate, retronatia, high metabolic score, low tongue position, right, blocking the airway also. Then crossbite, open bite, increased overjet, short lingual rhythm. And within their diagnostic criteria, criteria A, one or more of the symptoms, which is listed on the right side. And of course, go through the standard PSG, but also including the obstructive hypoventilation measurement, right, with carbon dioxide more than 50 mmHg for 25% of the total sleep time. So in the algorithm, you can see that if a child is already diagnosed for OSA, the workout could include, right, tonsil adenolectomy, and also using steroids, weight reduction, PEPs, and also expansion, mandibular advancement, and myofunctional therapy. And then AAPD also talk about early diagnosis, intervention, and oral habits management. So I want to include this slide because I think recently we do hear a little bit about the AAO 2026 white paper. And just to want to clarify, if we compare it against the table here, it is saying this, right? We do not diagnose. Yeah, I think all consensus paper concur on that, right? There's no diagnosis. Growth modification actually not contradicted, and all the other papers talk about as on its own right that we should, as dentists, already start managing it like an early intervention process. Orthodontics appliance have a role, is not as preventive, yes. Then for consensus paper is conditional. APPS is in the algorithm, and then APPD is having a cautious look at it. Yeah, not. Then for orthodontic treatment prevents sleep-related breathing disorder or sleep disorder breathing. AAO says no evidence. I think again the rest are not claim, not claim, not claim. All right, and we don't use imaging for diagnosis. Again, PSG is still the gold standard. So I think it's very clear. There's no like say resistance, I would say, to have our dentists, right, looking into this, treating early, because there is all the signs and symptoms of a dental-facial growth deficiency, right? And we should then escalate the child, right, for more tests, and as we can suspect breathing issues that can be mounting to even obstructive sleep apnea. So we should call for action, right? Screen for pediatric OSA and treat dentofacial with myofunctional therapy as well. So for the screening protocol, we can look at this pediatric sleep questionnaire, PSQ. Most of the time, we're also looking at the clinical signs. In understanding that this is really a short period for this whole presentation, right? We have a lot of details that will be presented on the one-day training program, which I will provide when I travel to Asia and even to our friend in, like say, our colleagues in Europe. But in the meantime, I will try to compact a lot of information into this so that we can have a broader view first. Yeah. So for the clinical signs, really as dentists, we do look into the mouth and we look at constricted arches. We look at a lot of different way of the teeth having malocclusion, right? But I think before we look inside the mouth, we can also look at the face, right? For example, the dark eye ring, the open mouth posture, the forward head posture, the mandible being retruded, right? And if we look further beyond the oral cavity into the throat, yeah, the tonsils, hypertrophy, all these offer us really some indicators that the child might be at risk. So we're not developing them to the kind of size and volume like the two prehistoric kind of skulls on the left side of the screen, but we're seeing more and more of the combination of this malocclusion features that is in the 6 to 8 year old child, right? And if we look, we can broaden it, or shall I say, consolidate it to three areas: craniofacial, intraoral, and functional, right? And these are the list of things that will indicate, yeah, that there will be some dental-facial anomalies, and we should act on it. Especially on the functional side, knowing that they have daytime sleepiness, or sometimes paradoxically they are very active if they are not sleeping well, um, sweating, and also uh, nocturnal enuresis, right? These are all signs that we should be asking for, and maybe helping the parents to understand that is more to be done. So a lot of the cases do come to us complaining of clenching grinding or bruxism. So very interestingly, many years back, we introduced this whole concept that sleep bruxism is in respiratory medicine. And of course, Professor Jules Levine, when I was in studying in US Tufts for the sleep mini residency, yeah, he's one of the mentor, and he was also invited by our um, dental school to actually talk about the relationship between sleep bruxism and apnea, the association, right? So we can read that the definition is interesting as involuntary, episodic, repetitive jaw movement, and secondary is occasional tooth grinding and clenching. So the main thing is really the rhythmic mascatory muscle activity that is moving, and this is also in an act that we want to open our airway to catch our breath. That's why clench and grind, right? So we need this multidisciplinary team to look into it so that we can identify, um, share out the load, and manage the patient, right, in our own respective area of professionalism. So what we want to do is we want to move from a reactive past to a more proactive future. So what needs to be done is in the clinical workflow, there will be more of this part where not only that we do our own work, but also we are identifying and screening for the risk factor in regards to pediatric obstructive sleep apnea or any related sleep-related breathing disorder. The referral is interesting. It's not only just unidirectional, but it's more from a bi-directional kind, where I'll demonstrate to you that our physicians is also sending cases to us so that we can continue the work, maybe after their surgical intervention, yeah, to improve on the dental facial component. Then diagnosis, treat, of course, diagnose by the physician, and treat depending on the devices, how we can intervene. Verification can be a home sleep test for titration, and then, of course, continuous management under the physician for long-term care. These are the ENT network where these are the four ENT that I work closely with, refer to. Unfortunately, to say that Dr. Adrian Sarajan has passed on earlier. He has been one of the most or the strongest advocate of this collaborative work for the past 2 years. And I'm sad to say that, yeah, I lost a good colleague back to us. But of course, we move on, and with his wife help, Chenny, we're also in contact with Dr. Lau to continue some of the patient that we have been working on. And now we're talking to also and working with Dr. Kenneth, Dr. Yuan, Dr. Vias, right? And on top of the ENT care, we do have our physiotherapies like Dr. Samuel and his team to look into the other aspect of the facial muscles and diaphragms, to help a patient to breathe better as well. So in this algorithm chart, when the ENT see that and refer back, right, it's interesting that we are now then taking care of the patient on our side, right, and we do our own malfunctional evaluation, right, and one first thing, of course, we talk about the habit correction. So our team of speech therapists, they are also orofacial myofunctional therapists as well as summer therapy, will help to help patient, right, to regain back the capability, right, in the few areas like lip seal, tongue up, posture, proper nasal breathing, and also proper swallow, right? So we depend very, very much on them for the myofunctional rehabilitation. And of course, we integrate that into, for me, growth development, non-extraction orthodontics, TMD, and sleep medicine, right? And of course, I need help. And when I look around, and finally, Smarty provide a full menu of choices. But of course, when I first start out, it's also usual paralysis of choice. How should I say it's a paradox of choice, right? Have so much to choose from, you don't know what to do with it. Of course, working with the internal team, talking to the experts, and also have my own thinking process. I've distilled down to this few features that's really very helpful in helping me to achieve. And now we are um, collating it as the AG KIDS system. A for airway, G for growth, right? One of the component is the S8 SGHB plus, which is very interesting with the Herbs appliance wing and also the vertical twin block support, right, for the occlusal support. So with this S8 device, we are able to control the sagittal and vertical component. Then the S11 palatal device help with the horizontal expansion. But on its own, of course, we know that it will be limited ability. But to me, it is more like working with the tongue, right? And we're using the tongue again, right, as the rightful expander of our palate so that we can control the transverse part. Then, of course, we need to improve on the myofunctional component, and all aligners systems do not provide this part of the support. And I'm very, very glad that Smarty has already a system in place, and they have trainers in place in terms of the Joy, right? It's like a full arch system where you can use it for learning, for lip seal, chewing capability, and also the Smiley, where you can actually put it in between your lips to train your lip strength, right? We'll discuss more about this in the one-day lecture. But in the application point, back to this 8-year-old. So he was a child that was referred back by the ENT. And after going through adenoid tonsillectomy, right, he still needs some help as the snoring continues and mouth breathing continues, right? The deep bite, retruded jaw definitely shows that, there is a lot of volume reduction inside the mouth. And that could also trigger where the tongue can rest, right, when he sleeps. And with a lip trap, open mouth posture, very difficult for him to maintain a good lip seal when he's sleeping if he doesn't change his habit during the day, right? So we move forth, of course, seeing the myofunctional therapist as for the rehabilitation. And then for the dentist, we go ahead and establish the bite position. We can determine a few relationship in terms of the bite, having the midline decided by where the tongue line is. We can take that as a reference. And for the sagittal component, we can look at the uh, canine, or if there's already a permanent uh, molar, we can use that and try to achieve as much as possible the molar class 1 relationship. After we scan, we can see. And for the vertical, sometimes we go for the edge to edge and also maybe 10% overlap. But in this case, because we can see that we need to build up some vertical, this is where I have established it. So if when the device is made, you can see that how the herb's wing, right, is being placed, right, to help hold the jaw in a certain sagittal position. Yeah, it is not, it is holding the position without changing the jaw more and more forward. So it's like acting like a mandibular advancement device. Then the twin block design offer the vertical support, and it's a very interesting system where it is not a square block, it is anatomically correct so that it can correspond to the opposing teeth direction, teeth, right, in terms of the bite. So the bite is more stable that way. Also, it is able to be programmed during treatment to shorten as the teeth extrude, as the bite plane is leveling. Yeah, it is actually dynamically changing, which is a very, very useful point. And of course, we have the S11, which straddle across the palate, leaving a space where the end spot is, so we can get the tongue to go to the end spot. But I use the strap like a tongue magnet. Of course, it still need um, intentional lifting, yeah, of the tongue to work towards getting this tongue in the right position. And you can see in some of my patients, if they get the tongue right, up there long enough, you can even see the crease mark on the tongue. So I know that they are up there. And during the progressive treatment, we can choose not to have them and allow the tongue to go even more intimate with the palate as the patient is more aware of elevation of tongue in the right position. So to me, sometimes the palatal expander may be, in a sense, overclaim, but we know that it is very critical, it is helpful, and to a certain extent also providing some anchorage, stability to the whole framework of the aligner to create the kind of expansion that we're looking out for, right? So it looks something like this. It can be applied together with the S8, S9, S10. So let's not get too bothered by that. Yeah, it's just the different features. Yeah, so we can actually have this, right? Uh, uh, Broadening transversely, but of course, as I said before, yeah, we have the tongue to help. So when you combine all this together, you have a tool now, right? That you can look at the sagittal placement, you can look at the vertical placement, and also helping with the transverse dimensional change, right? And for a deep bite with retruded jaw, we're able now to do a forward positioning, mandibular advancement, and holding it in place while we are adjusting the alignment of the jaw and promoting vertical growth, right? Not only from the dental perspective, but the whole craniofacial perspective. And then raising the bar again for the tongue to elevate, to use the tongue as the final or the rightful supporter, right? In the vertical component of the mouth in the oral cavity. So you can now compare this feature to the adult mandibular advancement device on the right, which is also Smarty product, right? That is already available. It's a SA and SA Plus, which is for sleep aligners, right? For also mandibular advancement feature, right? So that one on the right is particularly for the adult and who are, or should I say, who are already diagnosed with sleep apnea. The one on the left is the treatment features, right? That we're doing craniofacial, transverse, sagittal, and vertical component. But because of the herbs, you can see that it can actually hold yeah, the mandible in the forward position that we have established. And with that, right, the vertical uh, component is also holding, and we can help our patient to keep this position, similar to what a mandible advancement device. So now, in a way, we're able to create a mandible advancement device that is embedded in a active orthodontic device aligner that is doing multi-directional, dimensional correction, right, for the patient. So quite effective as a tool. So having that up there, I would, again, like I mentioned, use it to attract the tongue so that the tongue goes up to roof, exert the pressure on the base, right, of the maxilla, the green bone or the pink bone that you see, which encases the whole nasal passage. Yeah, so it's very important that the base part of this pyramid is properly expanded so that we can get the fullest of space and volume. And of course, when the child is wearing it, you can see that, yeah, the whole chin point is actually brought forward. Yeah. So on the smart check component, you can see that on the transverse side, yeah, on the right screen, how every step move the jaw and broaden it, and also open up the eruption space for the lateral incisor on the top right side. Yeah. So this is how a stage by stage movement. And then on the surface, you can see the vertical component, right? The TBs or the twin block designs. And then from the sides, you can see the HB, Herbst designs. And on the front, you can see another interesting blue extension. That's the lip bumper, right? So this is also very helpful in controlling the lip pressure towards the teeth, helping to balance some of the inward forces and helping the proclination of the lower teeth in the right way without too much compensation. Yeah. So by applying this over a period of time, wearing the aligners, in anticipation, of course, there will be eruption, exfoliation, and we may have to rescan and get a new set out. Yeah. We are treating this not really just for the dental facial component, knowing that the child has for especially for this case, already a background of OSA. Yeah, we need to intervene early to help him to breathe well as early as possible, and not just to wait for the rest of the teeth to erupt before we intervene. Yeah, so there's a certain level of urgency there. So this is him in July 2025, right, starting the treatment. And as early as March 2026, the last time I saw him before when he flew in from Indonesia, right, you can see that yeah, they will have already a closure of diastema, the eruption space is opening up, the lateral incisor on the upper right is already out, the one left is getting there, verticalization is happening, the bite is improving, right? Not only just from the again vertical, but also sagittal and also transverse. So these are a few other cases which you can see from here that the deep bite, right, and also even the midline deviation get corrected over the few months of wear, right? So from here, you can see also applying for this patient, right? There are the few components, the um, sagittal, right? There is the vertical, there is the transverse, and all this coming into play, resulting in a good translation of the repositioning of the mandible, right? While the rest of the um, teeth gets aligned. This other patient, you can see in also in October, midline is off, the canine is erupting, and by May, we are getting the midline. So sometimes the midline repositioning is more stable. So once you determine the midline and you have the wing component, you can really direct the jaw in the right place and it stabilize it there while the rest is forming, erupting. And from functional shift, we can also adjust, getting the tongue trained, guiding the opening and closing trajectory, right? It all push towards stabilization of the midline and the proper trajectory opening and closing. Another case, you can see also within a short period of time, the constricted arch with a tongue thrust component is also recalibrated and then closed in, right? Another case, right? So this girl, you can see on the lower right side, those are real kissing tonsils, right? Almost grade 4, right? So definitely immediate referral to the ENT, and she got her treatment follow-up, yeah, and scheduled for removal and to open up the airway from that perspective. Then on our side, we continue our help, right, to work on the midlines, work on the vertical, right? And you can see the interesting application of cotton rolls and toothpick, right, to help us to stabilize the position that we want, and so that we can do the digital scan, right? So again, this technique will do more elaboration during the full day training, right? And true enough, again, by June this year, we have a happy child. She's definitely sleeping better, breathing better, not only just from our perspective. Of course, you can imagine that after that, those tonsils are removed, she can definitely breathe better from that aspect. So then back to this patient that was again shown at the very beginning of the lecture. So this is how we present to us at 6 years old, right, in 2024, right? Mommy just came for a consult and we talked about it. And there you see, maybe a bit of lack of primate spaces also in the front. The two central incisors are erupting and we're not getting enough space. And this is the initial presentation in 2024, referred by a patient. And adenoid tonsillectomy has been performed in 2023 at NUH already, and snoring actually been resolved for 6 months. However, there's still issues. So NUH actually raised CPAP as a last resort. And second opinion already seek at KK Hospital, but the ENT has other perspective of what it is. Yeah. So this boy, long-standing airway and sleep picture. So breathing, snoring, mouth open, posture, pacifier used since age of 2, no breastfeeding history. So surgical issue is tonsils, adenoid remove, and transient 6-month improvement, then recurrence. And developmental component, the school teacher even suggested that he get some IQ testing and also want to rule out ADHD. Then on August 2025, parents seek another view as a sleep specialist in Vietnam. And the lower jaw position is being highlighted as an inward due to breathing through the mouth, as the physician highlighted, causing the tongue to fall back. This is their words, which prompted the recommendation to see an orthodontist. And they understand that I do work on this area, and mommy saw us. This is his sleep report. You can see that his OHI literally is 60.75, 60 episode, where 10 is already severe and is way beyond the charts, right? So from the dental perspective, looking at it, we can't tell, definitely. Once we do the test, or the test was already done, you can see that it actually throw up a very, very stark and severe situation, right? Yeah. Okay. So since the treatment is ongoing with the medical side, we went ahead and offer, right, the 2-year program, starting with the AG aligners to have the blocks and yeah, reposition, and of course, myofunctional therapy. All right. So that's him at 7 years old, right? Again, lower teeth are erupting with the four central and lateral incisors, finding it hard to have the good alignment because space is a constraint, right? So we reposition, and he's on the liners, and we are working on the myofunctional component. You can see that attended by the parents, working on the myofunctional component, snoring, mouth breathing before tonsils and adenoids were removed, right? Daytime, and nasal, more nasal in the daytime, but mouth breathing during sleep, right? So from the assessment, of course, our myofunctional therapist, the speech therapist, went on to work on him. I also identifying the range of motion, the strength of the tongue, clicks, yeah, and also noting snoring with both closed and open mouth. Yeah. Then after the second session, we really noticed that he's getting better. Yeah, snoring improved approximately by 50%. Again, a subjective evaluation by mother with the aligner wear. And lip closing during sleep now, right? And more improvement. And by the third session, right, mom already noticed that snoring improved, and now is closing his mouth during sleep. And he will snore without the liners. Yeah, with the liners is really helpful, right? So the liners work like this, and true enough, this situation for Bernie is that there's a lot of exfoliation and eruption, and we do have to see him generally more often, right? And with a new sets of liners all the time, right? So, but it is necessary, and this is the kind of system that is helping him, and mommy can see that he's breathing better, sleeping better. Uh, and you can see that he can control his tongue now with a good elevation. And we're still improving on the whole dental facial component for this patient. Then he's now scheduled to go back to uh, Vietnam, yeah, for good. So at this point, when we evaluate his bite position, there's a more stable bite that's not as deep and and in a good relationship. So we decided then to just do one without the herbs, no wings, no vertical. Yeah, still have the palatal strap. But mommy, after receiving this liner, noticed that uh, within 4 days, patient is snoring, opening up, and not sleeping well again. So the mandibular advancement feature of this appliance is significant in this particular patient's case. Yeah, it's literally like a mandibular advancement device that is useful for him, right? So with it is very reduced the snoring, breathing is much better, daily function gain, can sleep better now, more concentration during school, improve sports performance, less fatigue in hot weather, remaining energetic, right? So and we can see improvement in the myofunctional component as well. Yeah, so the wing that is omitted is now going to be placed back again. So we're making a set immediately, right, with the wing, and it will be delivered within this week or two, right? So yeah, we can see how important that is for that case. And so the last case that we'll talk about is also a boy at 9 years old, also referred by the ENT for dental facial assessment. So what is necessarily done on the ENT side have been done, and now we have to manage the dental facial component. So there's tongue thrust, there's constricted arches, lack of primate spaces, leeway spaces, high arch palate, lower lip trap, and anterior retroclination, right? And you can see the arrested caries already. Okay, again, more mouth breathing, drier mouth, higher risk of decay, together with a clench and grind. Yeah, all these are the multiple whammy, I would call it, that create this problem. So At maximum intercuspation, there's a functional shift, right? The tongue line will relocate. Then we use that as a reference, as the center position. Then we take the necessary bite and we scan, right, to provide the digital mount. And then from there, we're able to then create the model and work on it, right? So, and then including the S8SG HB Plus. So we combine all the systems that is useful and then adapt it according to our need. And then this is the prospective bite that is planned out and we move towards it, right? So in August, we started with that. And in March, again, we're seeing improvement. But more importantly, while using the device, you can see the general um, demeanor, and the energetic level of the child, right, has improved tremendously. So much more awake, alert, happy, right, compared to when he first initially came, and really, there's a big difference. So I think as a dentist, we are definitely able to contribute, right, to improving this component, right, through adaptive system using multiple appliances in a very creative way and redesigning it and then creating the system that has been, like say, impactful in terms of helping children with airway issues and helping them to grow better, right? So with that, I thank you. I'll stop share first. Okay, so I think we do have a bit of time. Hopefully, we can get some questions and you can ask.
Yeah, Dr. Yu, can you please check the chat box?
Okay.
Some doctors ask you the questions.
Yeah. Okay. Hi. So, JS, Dr. Chu, compared to the conventional fixed maxillary expander, what is the limitation for the S11? Is it strong enough to skeletal expansion in early mixed dentition stage? Okay, so again, I want to explain this component. Okay, so for a lot of these expanders, either a mini dome, mini MAPI, yeah, or a removable type, we are working on the expansion. Transverse dimension. But when the system like this is inactive, like the AG kits, we're looking at multiple dimension, looking at transverse, but also looking at vertical, looking at sagittal. And when the alignment is active, what I've noticed, because when I move into children, I also have been actively treating adult patient, non-extraction with aligners, with tongue action, and we are able to cause more changes to the palatal component. So my concept is slightly different from the standard where, yeah, we are focusing on the forces and such breaking sutures, moving that. There's no wrong. I say this is one way to go about it. But for this other method that we are doing, we're returning the body to its neutral form. So if you think about it, how can we grow our jaw in the first place? Is by closing the mouth, putting the tongue up. We're born with a baby tongue. As our tongue grow, the tongue will become a certain size. And if it's always up against the palate, our palate will grow proportionally to our body, relative size. Each of us will have a different size required. Right? So I want to reapply that natural force, right? So the S11 is helping to establish some forces, but it's more to me again, like say, getting my tongue closer to that palate, especially the posterior, mid and posterior part, not just the tip. I want the mid and posterior. So it is really from the tongue. That's why we still emphasize a lot on the myofunctional therapy. Swallow well, breathe well, rest well with the tongue up against the palate. So you have to not take it out of context and say how S11 do the job. you have to take into context that S11 is working with together with all the different features, a liner, working on teeth, moving the roots, activating the alveolar bone, having the regional acceleratory phenomenon, right? And then with the myofunctional component, re-establishing the tongue function, swallowing 1,000 times, breathing 20,000 times, resting the tongue all the time, then we're actually growing the jaw again. You see, it's not just S11 pushing open. Hopefully that helps in answering. Is expansion sutural or dental? Right? When you are able to put the tongue up and expand out the natural forces back into the whole space, it's three-dimensional. Yeah, it's sutural, it's craniofacial, right? We're opening up the whole space over time. All right. So we're not asking for a quick fix. Yeah, so it's always the tongue being able to come back into the space. So that's why for me, I've not done I won't say zero. I say most of the extraction done for orthodontics in the last 19 years I'm doing aligner is very selective for very specific reasons, but not for space creation per se. Yeah, I've not done any. So all these cases are created, or should I say, completed with the help of myofunctional therapy to re-establish some space and volume. Yeah, really will be happy to share more cases, both children and adult in this area. For class 2 early mixed dentition, what is too early to advance the mandible? Yeah, I think there's no too early. Of course, my youngest patient is 5 years old. Still all deciduous teeth. Interesting is that again, she's also diagnosed to have sleep apnea, and she came for consult. The person that opened up to me later on to tell me all about he's seeking this kind of help, but not able to get it, is his father. And the father is actually a radiologist, a doctor, who also is very clear about what he needs to do for her, but non-surgical and want to direct growth. And the child is not so, like, say, ready, right, in that sense, wearing all this liner, but that says he's going to help her to follow a routine. And true enough, she managed very well. Uh, the first week after using those aligners, already subjectively, daddy is also reporting that she's sleeping better. Jaw is being helped forward, right? Yeah. So we are seeing this kind of improvement, and of course, with future collaboration, there will be more definitely research, stage kind of sleep test to really quantify the improvement that is. But that said, we are not just like how I presented in the whole discussion. We're not just looking at the 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 sleep component that we're trying to improve, right? We're talking about our craniofacial, right? So if we do this part well, I think it will have that very positive influence to the whole breathing part. Yeah. Then yep, Dr. Louis Chan, high five, and definitely I think we're all on the same track, right? Yep. So do you use so Emily, Dr. Emily Ng asked, do you use lip bumper and herbs for all kids? So the answer is most of the time I do see many of my children having a more retruded jaw and also a vertical deficiency. So I look at it another way, like this whole concept of mandible advancement. If you understand Smarty, you need to understand one person, Professor Seng Kang, who came up with the GS system, right? And this is the population of the whole features to the different departments, right? Different product lines that actually help to improve on the outcome. So GS has a different way to also classify class 2 malocclusion in 5 different ways. Yeah. So for me, I also look at it in like this way, where simply a class 2 can be a class 1 malocclusion with vertical deficiency. Yeah. So if we position the jaw correctly to class 1 incisor, class 1 canine, yeah, sometimes even class 1 molar, we can see that it's just because of vertical deficiency. So we got low tongue, all this increase curve of speed, right? So if you can improve on the verticalization, right, we can solve it like a, a class 1 malocclusion, just work more on the vertical. And definitely the repositioning with the HB and the vertical uh, help me to achieve that kind of work that I want to do. Then after expansion and correcting overbite, quite often the lower jaw comes forward without the wings. Yeah, I think you're right, is in the sense that we are also aided by the fact that the child is growing, there's growth hormone. Yeah, so sometimes it's not just from our appliances, it's also from the natural growth. And if you get them to close their mouth, yeah, keeping the lips together also help to draw the jaw forward. If their mouth is open, the rotation of the jaw in a clockwise direction also bring the lower jaw backwards. And then we have collapse of the back and the higher angle. So if your tongue is up, we can actually have a more horizontal, more level kind of mandibular angle as well. So true enough, yeah, there's an interplay of natural growth, repositioning, and maybe even for the myofunctional component, not only just appliances or the aligners. Of course, if they have OSA, the wing would help in the Bernice case. Yeah, okay, appreciate your thanks. So yes, so JS asked again, how about cases with severe narrow arch form, need bigger expansion, more than 6 mm? Again, I think this is really a decision of the doctor. If you need more, you want to split suture, I say you can go ahead and use the other appliances. There's no stopping you from doing that. If you are well trained and you are able to control the case, so be it. Yeah. But for me, it's just that like say my methodology use the tongue a lot, yeah, and the tongue is able to deliver the system, or should I say the outcome, not only at the stage where I am treating, but after the rehabilitation, after the completion of the treatment phase, the tongue continues to grow with the patient and continue to exert its pressure in the right way if the function is correct, and it will be a long-term improvement till it's resolved. Yeah. So I sometimes use this analogy. I'm shooting the person back into orbit. As long as into the right orbit, yeah, everything is going to be right and right and right. If it's in the wrong habit, and then you have the wrong spiraling down and get worse and worse and worse. So where do you want that person to go? It all depends on how you actually plan for it. And the other part of the question is that if we have to correct the bite after expansion, would you suggest anterior bite plane helps or mild brace? Yeah. So we have to correct the overbite after expansion. Yeah, so literally you can correct the overbite with the vertical component, the TB, or now is added into the HB, right? Sorry that we're using all this acronym because the Smarty Smarty classify them very specifically like this. But I think I try to help you to understand that S8 is a system, right? Number 8 version. I'm sorry, number 8 category. And then you have your HB herbs one, and the TB is your twin block. Then if you use the herbs, initially they don't have the twin block. But now because the herbs is also helpful, so now herbs with the twin block, right? Then you get the HB plus. I hope that clarify. So yeah, you can actually use that throughout. Okay. So you can control your sagittal, your vertical, and your transverse all at the same time. So you don't have to literally add anterior bite plane. You can already use the TB to actually guide. But if you really want the anterior guide plane, yes, there is also an anterior guide plane feature you can choose. Yeah. So it is to your innovation. So I'm trying to make it simpler first, right? Having this few features, not too big, too complicated. We can do a lot more, a lot of work already. Yeah, then we have one doctor asking, may I know what is the age limitation for S11? To a certain extent, there's no age limitation. I use it for my adult patient. Again, to help, if we can do a bit of dental expansion, so be it. And next is I use it as a guide, as like a trainer to my patient. So I want them to be in contact. So my first phase stages usually include the S11, and later on, I might take it up. Yeah. when the patient is ready. Mm. Is the retention with herbs and wings sufficient? Generally well. Yeah. They week by week they change, and there's a lot of strength in it. It's quite well made. Yeah. And I think again, it's about really keeping the lips together, putting a tongue up, rather than just depending solely on the wing component to sustain the sagittal positioning. Yeah. So I think it's again a combination. Uh, I think I always say to my patient it's a negotiation. I say you must be willing to change your habit before I start, because I don't want to fight with your lips. I don't want to fight with your tongue. I don't want to fight with your swallow, right? So if you still want to do all those old habits, we don't want going to get new results. So I think it's very clear upfront that we are, talking about this clearly, so that the patient knows what they're going into, right? It's not about just wearing aligners, it's about habit correction as well. I think that is also a very clear feature of AG kits. Yeah, the myofunctional component. So of course, we are in the early announcements phase of this new product, but we are going to definitely incorporate the trainers into the system. So out of the box, you will have your Joy Joy and your Smiley Smiley, and there will be myofunctional trainer systems that will be incorporated as we finalize on that for the providers. Mm. Last question. Oh, sorry. One more question is that is it available in India? I think I'll leave it to the team. At this moment, I think there's no distribution network in India yet. Yeah. So do I use Joy Joy, Smiley Smiley? Yeah. So yes, they are part and parcel of our additional training systems. So I sometimes leave this to my myofunctional therapist to incorporate. Yeah, but if not, then like I say we will be able to share some of the simple treatment, like for example, yeah, just a simple pull and tuck to train on the myofunctional, and also wearing the device, simple chewing activity to activate because chewing is about activating the cranial nerve, trigeminal nerve, facial nerve, hypoglossal, ready for your swallow, your pharyngeal muscles, yeah, your vagus nerve. All this. It's not just about using it to change the alignment or the grow the bone. It's about coordinating the neural systems. Yeah. Then sometimes I ask them to close their mouth for 2 minutes, holding the device. Yeah. And from 2 minutes, they can able to gauge how much strength they are closing the mouth, and then hopefully without the device inside the mouth, they're able to exert the same capability to close. Yeah. Um, do we need to record the protruding bite when prescribing S8? Ideally, yes, yeah. So you will provide two bites. One, the neutral bite, so I say the habitual bite, and then the one that you're repositioned, right? So adjusting for midlines, adjusting for sagittal, adjusting for vertical, right? Then you're able to scan that in, and they will be able to provide the change in position for you, repositioning. Katrina, Katrina asking about whether it's available in Australia. It is a resounding yes, definitely. Yeah. Oh, so I think not available at the moment means India, is it?
Yeah.
Okay.
Mm-hmm. I think that's all the questions from the doctor. Thank you so much, Dr. Yu. Excellent webinar.
Thank you. Thank you. Right. So
Thank
hopefully
you.
we'll see you all when we go to the respective country, right? And see you all soon.